Yes.
I just have a handful of questions that I've been asked to ask you. Well, first of all, can age add to the complications of advanced liver disease, in your experience?
The average age of death in chronic liver disease is much lower than the average age of death generally. So in the UK, the average age of death from alcohol-related liver disease is 54. For all-cause liver disease, I think it's 59. And so we do deal with a relatively young adult patient cohort. In terms of advanced age, it tends to be associated with increasing comorbidity and increasing physical frailty. And when age and frailty increase, the physical reserve to recover from insults or also reduces. It reduces options in terms of transplantation because there's a requirement that your median life expectancy would be 5 years post-transplant for you to be eligible. And that's less likely to be the case if you're in a more elderly group. Yes, age does impact upon prognosis and therapeutic options available.
I think, but it can be both ways as well. So I think with the younger age patients, we talked about the fact that if you're of working age, then that in itself can have problems beyond the physical complications of the disease, and the same for your carer. If you're in your 40s or 50s, then the chances are you're going to be looked after by your spouse, therefore, and you may have dependent children. So there'll be the difficulties, as we've talked about, the holistic challenges. So I think age, you couldn't really give any particular pattern.
Dr. Hudson, you've indicated that you've seen a number of infected blood patients with advanced liver disease. Has this been increasing or decreasing over recent years?
It's been, I would say, it's in my personal experience, it's been decreasing, but it is still real and live. And it was more common as a kind of junior registrar or senior kind of SHO, so more junior doctor in training. It was more frequently that we were seeing this, but it is you do still see new presentations from this.
Would you accept that the infected blood liver failure patients are a specific cohort with a very particular history and therefore very particular needs, who are also perhaps more likely to be literate and health literate than the average?
I think in terms of the literacy levels, I think on balance it is likely that they will be a slightly different group to the majority of the patients that we see who, so in the UK, around about 70% of liver disease is due to alcohol. A lot of those patients that we've talked about have maybe had challenges earlier in life that mean that they may not have completed education to the same level. So I think from a literacy point of view and potentially from a socioeconomic point of view, they may be a slightly different group. But I would say that there are probably different challenges for lots of different groups of our patients for different reasons.
And what could be done, do you think, to improve the knowledge and understanding of that patient group amongst palliative care clinicians and hepatologists?
As in the specific to the infected blood?
So it's specific to the infected blood cohort and their, as we just talked about, their particular history and their particular needs. What could be done to improve the knowledge and understanding of that group?
I mean, I think often things as simple as an explicit recognition of the injustice of the situation and the barriers they would have had to come across, and the pre-existing relationships with health and healthcare providers may have been strained, and that you may need extra recompense for that in terms of time, and that there's a recognition of the way they've acquired their disease that is not necessarily the case for other conditions.
Dr. Finlay, do you have anything to add to that in terms of supporting the knowledge of palliative care clinicians?
So I think there will be a lot of similar needs, regardless of the etiology of somebody's advanced liver disease. But I think recognising the specific psychosocial concerns and needs that this patient group may have is important. And I think that comes back to Ben's point of giving somebody space and time to articulate their journey, their experiences in the past, I think is incredibly important.
An entirely different topic. To what extent should palliative care principles be applied in compensated cirrhosis as part of a patient's anticipatory care planning?
I think it's quite difficult to give any generalisation. So potentially from a physical point of view, patients with compensated cirrhosis may well not have, unlikely to have a significant symptomatic burden. However, they may well have some psychosocial needs, and so it's about understanding the patients and having the conversations about how their liver disease is impacting on them as individuals to decide whether or not palliative care may be appropriate. I think in that situation it's unlikely that specialist palliative care would be required, but the principles of palliative care about taking a holistic approach to the patient would be valid, and it may be that in that situation, to try and preempt problems further down the line, we may involve other teams in their management.
And in terms of anticipatory care planning more generally, so both in decompensated cirrhosis and advanced liver disease, would it help to have an anticipatory care planning checklist nationally available with national training so that choices could be discussed in a systematised way?
I think that might help reduce unwarranted variation, but I think similar to the discussion we had this morning about any guidance or guidelines, it's dependent upon the individual clinicians and the teams that they work within actually using those. I think I think tools are very helpful for identifying need, and not everybody will have the same needs. And so any means by which you can do that, if that is a checklist, then that is very helpful. I think it's fair to say that there are some clinicians who don't necessarily agree with the checklist approach because it feels like you're less individualised in the approach that you're taking to somebody's care. It might introduce another layer of paperwork to what should be an individualised approach to a patient. If it's a catalyst to helping to identify needs, then great, but I don't think it always will work with every clinician and every individual.
Would you support the provision of specialist hepatology nurses within special clinics as a national standard of care in order to support the palliative care side of hepatology?
Yes, I think I would. I think centres providing care for patients with liver disease need to have a specialist nursing service to support the delivery of that care, and I think that should be a relatively core standard for units providing liver disease care. Would you agree?
I think the degree to which nurses specialise depends on the size of the centre. So you may work in a smaller centre where they'll have one nurse who will look after patients with viral hepatitis, patients with chronic liver disease, and provide a sort of a general liaison service between and support service. In bigger units, you may have specialist transplant nurses, specialist hepatitis nurses, specialist advanced liver disease nurses. So I think you wouldn't be able to have one model that would work everywhere, but acknowledging that specialist nurses are an invaluable tool in improving the experiences of our patients, I think is...
Specialist nursing is vital for delivery of hepatology care, not just in advanced liver disease. But
yeah. I think added to that, we mentioned this morning, and it's mentioned in our report, the feasibility study that was done looking at having an advanced liver disease nurse who was given training in advanced communication skills, so brought that dual role. And she followed patients home once they had been admitted and were being discharged after an admission because of their liver disease. And the beauty about that was that the individual followed that patient home and was able to link in with their GP, with their hepatologist and with other people in the community. So it was so well evaluated by everybody involved in that system, by the clinicians, by the GPs, by the patient and their family. So we have proven on a small scale that is very satisfactory to all concerned, and I think that should be something that is more widely available across the UK.
Are you aware of any studies or data sets that compare differences in palliative care provision between the 4 nations?
The short answer to that is no.
That's fine. And finally, does the fact that hospice care is frequently provided within the charitable sector exacerbate or simply reflect patchy palliative care provision?
I think my personal view about that would be both. There isn't the same access to specialist palliative care all over the UK, depending on where you live, and that can have an impact on you detrimentally. And it would be, as Ben was alluding to this morning, I think it would be really, really positive if it was recognised at a much higher level that specialist palliative care for everybody who needs it is a human right, and that has been dictated by the World Health Organization. That is not just my view. And so to, I think, bring specialist palliative care into the core and making it available for everyone who needs it should be a priority.
I'm just going to look behind me, sir. There's nothing else that I've been asked to raise, sir. Do you have matters you would like to raise with the panel?
Well, I only have one. It's for you, Dr. Hudson. Just shortly before lunch, you told us that liver disease was the 3rd commonest cause of death in the UK, and it was the commonest cause of deaths in people of working age.
I think it's soon to overtake ischemic heart disease as the commonest cause of working age death. And I think it is now the 3rd commonest cause of overall death. It was 5th commonest a couple of years ago.
Well, that's why I wanted to ask you, because anyone who reads the start of your report, if we can just go to page 1 of it.
It's page 3 on the document, sorry.
Page 3 on the document.
EXPG 5043.
It's just under question 9. If we just highlight that first paragraph.
Yes, so that was taken from the first Lancet report on liver disease, I think, published in 2014 by Roger Williams's group.
Yes, and that's
proportionally liver disease deaths have increased since the date of that. So I think liver disease is now, in that report it was the 3rd commonest cause of working age death, as in death in adults aged 18 to 65, and I think it's soon to overtake ischemic heart disease as the leading cause.
Right. So it really bears out what you start off by saying. There's been a dramatic increase in deaths caused by liver disease in the UK.
Absolutely, and that's been exacerbated even further during the course of the pandemic. So alcohol-related liver disease deaths over the course of the COVID pandemic have increased by a further 20%.
Now, and just on that, I imagine that having quite a lot to drink and suffering immediate serious advanced liver disease it doesn't happen
No, you're right.
the next day. So those people who have been drinking a lot for understandable reasons during the pandemic, are we going to see a spike of liver disease cases?
We are already seeing it, and there are liver conditions that can develop quickly and severely relating to alcohol. So the rates of increase in alcohol-related admissions are up 20% on where they were in 2019. There's a different specialist interest group within Basel that looks at alcohol-related liver disease, and their audit of that has been quite alarming.
It may not just be alcohol as well, with actually eating habits changing. We may see a spike in non-alcoholic fatty liver disease as well, where people have not been able to be as active, and potentially eating habits have changed with all the stress of the pandemic, and it may be that we'll see problems there as well, actually. I suspect that will take longer.
A wide variety of reasons relating to that. There are still cases of infected blood infections coming through. This is likely, is it, to increase the, if I can call it the noise, I don't mean to be disrespectful, but those whose voices are raised saying let's have more properly organised palliative care?
It hopefully will, but I think unfortunately sometimes the people who are affected by liver disease aren't necessarily people who are used to having their voices heard. And so I think one of the challenges we have is that whilst this is a big problem, and actually it's been a big problem for a long time, because of some of the stigma attached to liver disease as a whole, it does mean that even when people are shouting, they're not necessarily being heard. And so finding ways to amplify voices and getting them heard in places where a difference is able to be made is one of the challenges.
Absolutely. The stigma from liver disease has held back the specialty. If the leading cause of working age death was, I would wager a malignant cause, lymphoma or breast cancer, I imagine the public awareness of it would be much greater. There's still this misplaced shame around liver disease that it is in some way the patient's fault. And although clearly we've been talking about infected blood where it's clearly not, but it's also not the case for patients with addiction. It's also not the patients who come from very difficult societal groups and have been disadvantaged from the start. And that disadvantage takes them right the way through to their death. And so advocating for liver disease as a wider group has been a huge challenge over the past, 20, 30 years.
Yes, thank you very much. That's all that I ask.
Is there anything any of you want to add or amplify from what you've said already today?
Well, thank you very much. I wanted to thank the inquiry for inviting us. It's been a huge honour, and it's been hugely important for our subspecialty to increase representation, be able to describe the principles of palliative care, and to be included on the inquiry has been a huge honour. So thank you.
Well, I think it's I haven't asked, would either of you want to say anything yourselves?
No, only to agree entirely with Ben. Thank you.
Yeah.
Can I, for my part, thank you for giving us the privilege of being able to listen to you. What I think I've heard loud and clear in most of what you've said has been the importance of listening to the patient and acting on the patient's views of what is best for them, and except perhaps when it comes to telling them multiple MDT directly, but then that's more of an iterative process so that it still gets captured. So I thank you for that, and indeed for everything that you have in your report, which is very readable, and what you've been saying. Thank you.
Thank you.
So I wonder if we might take just a 5-minute break before we hear our next witness.
Yes. Well, not before. Well, we'll make it 22, shall we? It's a rounder figure. 22.